discuss about the tachyarrhythmia in the children's. At first, we have to understand what is normal heart rate. No, as we know that in the adult population, we know that the normal heart rate is 60 to 100 beats per minute. But in the pediatric age group, it differs with the different age. From the newborn to adolescent age group, the normal heart rate varies. And this is the table from the Nelson that shows the normal heart rate in the newborn is 70 to upper limit is 190, or average heart limit is 125. And also all the normal heart rate in the different age groups. We then discuss about the normal conduction pathway of the heart. Conduction pathway that sinus SA node is the impulse generated from the SA node. SA node then it travels to the AV node through the anterior internodal tract, middle internodal tract, and posterior internodal tract. Then it comes to the AV node. AV node through the bundle of his. It goes through the interventricular septum by the right and left bundle branch, and goes to the ventricular muscle through the Purkinje fiber. And also from the SA node, it goes to the left atrium to the Batchman bundle. Then pediatric arrhythmia. Pediatric arrhythmia is defined as the normal heart rate or rhythms. That can be the tachyarrhythmia or bradyarrhythmia. That can be generated from the atrial or junctional or ventricular or any type of heart blocks. But today our topic of discussion is tachyarrhythmia. Definition: as the rapid heartbeat that may be regular or irregular but out of proportion of the age and level of exertion or activities. Then come to the symptoms. The mother generally presented with complaining that the child having the palpitation, lightheadedness, syncope, fatigue, shortness of breath, chest pain. But in the case of the infant, those complaints are not that evidence. So in the infant, we got the poor feeding, tachypnea, irritability, sleepiness, pallor, and vomiting. Also, there are some hemodynamic instability like complications, that respiratory distress, failure, hypotension, poor organ perfusion, like increase the capillary refill time, loss of consciousness, or sudden collapse. Yes. Yes. Then come to the cause of the tachyarrhythmia. That can be the primary by some underlying causes or secondary. Secondary causes are basically reversible. That's the hypovolemia, hypoxia, hypoglycemia, hypothermia, hyper or hypokalemia, and acidosis. And toxin or cardiac tamponade, tension, pneumothorax, thrombosis like coronary or pulmonary thrombosis, and trauma. Yes, sir. Yes, sir. But in the initial phase, we have to compensate the cardiac output of the body for tissue or organ perfusion. That's where the tachycardia. Then the tachyarrhythmia originating from the atria. Sinus tachyarrhythmia, sinus arrhythmia. Sinus arrhythmia, normal physiology of the heart rate varies with the respiration. Generally, the heart rate slow during expiration and increases during the inspiration. The drug like digoxin exaggerated it, and it also abolished by exercise. This is the ECG showing. Yes, sir. Okay. This is the ECG showing the sinus arrhythmia that varies with the respiration. This point, there is a P wave and there is a RR interval, is a large RR interval in between point and that point. So there is a varied P interval, but no significant change in the P morphology or PR intervals. Then sinus tachycardia. Generally, sinus tachycardia, when the SA node sends the impulse faster than the normal heart rate as per the age group. In the response to the body need, increase the cardiac output, like in the condition of like exercise, anxiety, fever, hypovolemia, circulatory shock, anemia, congestive cardiac failure, administration of catecholamines, thyrotoxicosis, and myocardial diseases. Here the P waves are present and normal but narrow QRS complex, and beat to beat variability is present. This is the ECG for sinus arrhythmia, sinus tachycardia. And premature atrial contraction. It is a benign, but in the absence of any heart disease. So most commonly in the newborn. That can be the depending on the prematurity of the beats. That premature atrial contraction may be result from the result in the normal or prolonged, that is a conduction to the ventricle through the aberrant pathway, or absent QRS complex, that the impulse did not conducted to the ventricle. The upper ECG showing the impulse conducted to the ventricle, so the aberrant pathway, there is a overlapping of the T, and here is a overlapping of the T and P wave, and showing the narrow QRS complex. And in the lower ECG lead, there is a overlapping of the P and P wave, but there is a pause in the QRS complex. There is no generation of the QRS complex after the P wave. Wandering pacemaker. Pacemaker shifted from the SA node to the different atrial site. Normal, it is a normal variant, but irregular rhythm. Here it is shows that in the ECG that P waves is a down directed or negatively deflected, and in some here the P wave is positively deflected. So there is a wandering of the pacemaker, so that the different P waves are formed. Then supraventricular tachycardia. It is the most common abnormal tachycardia in the pediatric case. Yeah, it is generally originated above the. So, and in the age of presentation in the first 3 months of the life, and second peak is the 8 to 10 years or in the adolescence. It is paroxysmal but sudden or onset or offset. It is occasionally occurring at the rest. In the infant, it is precipitated by infection, but in the children, it is precipitated most commonly by the bronchodilators or nasal decongestant. The rest of the SBT is vary with the age, but it is generally more than the 180 beats per minute. The short paroxysm doesn't hamper any case, but in the long attack, that is more than the 6 to 24 hours, or heart rate is more than the 30 beats per minute, lead to the cardiac failure. In the older children, we generally presented with the palpitation, but in the younger children, the basal heart rate that for the age is greatly with the crying. In this ECG, there is difficult to identify the P wave, but there is the 1:1 ratio of the P and QRS complex with the normal QRS complex. This ECG is similar to the sinus tachyarrhythmia, but there is a difference. Is more heart rate is more than the 230 beats per minute with the unvarying heart rate and abnormal P wave axis EPC. Then comes to the supraventricular tachycardia, can be the 3 types. Reentrant tachycardia with accessory pathway, reentrant tachycardia without any accessory pathway, and ectopic automatic tachycardia, that is AVNRT, AVRT, atrial ectopics, junctional ectopics, atrial flutter, and atrial fibrillation. Now comes to the basic management of the supraventricular tachycardia. Some non-pharmacological managements like placing the ice bag over the face, Valsalva maneuver, staining or breath holding that can slow down the heart rate by vagal maneuver. If the children is hemodynamically stable, we can push the adenosine, IV adenosine of the rapid push. But in the older children, we can use the calcium channel blocker like verapamil, where the calcium channel blocker is contraindicated below the 1 year of age. This is the technique for the rapid push of the adenosine. That is the adenosine followed by the rapid push of a normal saline, so that it goes to the heart very rapidly, and because the half-life of the adenosine is around 10 seconds. Yes. So adenosine goes around 100. We can start off the 100, goes up to the 300. If the children is not stable, if the child is not stable, then we can go for the synchronized DC cardioversion, the 1 joule per kg. If the tachycardia is resistant to the IV adenosine, then we can prefer the IV procainamide, quinidine, lecanemab, chatolol, or amiodaron can be tried. If the SVT is still persisting, we can go for the catheter ablation with the success, which the success rate is 80 to 95%. And other methods are the radiofrequency ablation, cryo, and surgical ablation in the most resistant cases of SVT. Then maintenance therapy. If the sinus rhythm is restored, for the long-term maintenance, we can use the beta blocker both in the WPW and non-WPW syndrome. Digoxin can be given in the infant, but with the no accessory pathway. Yes. Then come to the discussion about the atrioventricular reciprocating tachycardia. It is the most common tachycardia SBT in the infant. Reentrant tachycardia with the accessory pathway. The flow of the impulse may be bidirectional or retrograde. Ebinodal reentrant tachycardia. It is common. It is a common form of the SBT in the adolescents. Involves in the basically two pathway with the AV node. It is precipitated by the exercise, presented with the repeated syncopal attack, but it is good controls with the antiarrhythmic therapy. Beta blockers remain the drug of choice for the maintenance. Atrial ectopic tachycardia. It is uncommon in the children. Usually heart rate is variable more than the 200 beats per minute. Due to the single focus of automaticity, on starting the pharmacological therapy, the tachycardia gradually slows down, but it goes off again. And ECG show the ectopic P wave in the with the abnormal axis. Multifocal atrial tachycardia. It is most common in the infant than the older children. Characterized by the 3 or more ectopic P waves and varying PR interval. Spontaneously resolution occurred by at the age of 3 years of age. This is the multiple atrial tachycardia, where the different type of ectopic P waves of the various PR intervals. This is the P wave and P wave, various PR interval and various RR interval and various morphology. Junctional ectopic tachycardia. Due to the abnormal focus in the automaticity, the focus being a conductive tissue very close to the AV node. that discharge the impulse from the junctional tissue and exceeds the avinodal discharge and causes the AB dissociation. It occurs in the early post-op period, maybe or any early post-op period, or maybe during the congenital cause. If the IV amiodarone can be drug of choice in the post-op junctional ectopic tachycardia. In the congenital junctional ectopic tachycardia, catheter ablation can be used on maintenance therapy by the amiodarone or satalol. Atrial flutter. It is usually called as intra-atrial re-entrant tachycardia, where the heart rate is more than the 400 to 600 beats per minute in neonates and 250 to 300 beats per minute in the children, due to the re-entrant pathway located in the right atrium circulating around the tricuspid valve annulus. AB dissociation occurs and ventricular rhythm responds to the second to fourth atrial beat. It occurs in the neonates with the normal heart rate, or in the children with the congenital heart disease due to the overstress of the atria. This is the rapid, irregular, sawtooth-like flutter waves are present in the ECG. These waves are the sawtooth-like waves. That can atrial flutter can be managed by vagal maneuver, adenosine, or calcium channel block. DC cardioversion, synchronized DC cardioversion can be the treatment of choice. The patient with the chronic atrial flutter can develop the risk of the thromboembolism or stroke. That's why we can use the anticoagulant therapy during the treatment, and maintenance therapy by the type 1 or type 3 antiarrhythmic agents. Atrial fibrillation is the very uncommon in the infant or children. Heart rate is more than the 400 to 700 beats per minute. It is irregular rhythm with on ECG as well as in the pulse. It is generally so in the post-op surgical cases or in the congenital heart disease with the enlarged atria, thyrotoxicosis, pulmonary embolism, pericarditis, or cardiomyopathy. Yes, yes, sir. There is a congenital heart disease mentioned. In the stable cases, we can use the calcium channel blocker or IV procainamide or amiodarone can be used if not controlled by the calcium channel blocker. If the case is unstable, we can give the DC cardioversion. This is the way. This is the ECG for atrial fibrillation, where the absence of the P wave, irregular ventricular response. There is no proper RR interval, because the RR interval is not same in the different impulse beat. Flutter and atrial fibrillation. Arrhythmia originating from the ventricles. Premature ventricular contraction. It is uncommon in the children. It can be unifocal or multifocal, abolished on the exercise. If the unifocal or disappearing with the exercise, or if unifocal or disappearing with the exercise, or associated with the normal heartbeat, then that can be considered as a benign one and no therapy is needed. The advise the patient to avoid the caffeine and other stimulant agents. Here, this is the ECG showing the premature ventricular contraction, early or white QRS complex with associated with the sinus rhythm. Also, sinus rhythm also is present. So the bigeminy with the sinus beat followed by the premature ventricular contraction. This is a repeated pattern as it is frequently seen. Ventricular tachycardia (VT). It is defined as the at least 3 or more premature ventricular contraction or heart rate is 120 more than the 120 beats per minute. That can be paroxysmal or incidental. Associated with the myocarditis, anomalous left coronary artery, mitral valve prolapse, or primary cardiac tumor, cardiomyopathy, or post-operative cases. The prompt treatment to prevent the degeneration to the PF. Generally, the VT can turn into the rapidly into the PF, that is ventricular fibrillation. The ECG shows the white QRS complex. P waves is unidentifiable, not related to the QRS complex. In the case of the ventricular tachycardia, we can it is if the patient is stable, we can treat with the amiodarone or lidocaine or procainamide. If the patient is unstable, we can give the DC cardioversion as a treatment of choice. Ventricular fibrillation. In the children with the long QT syndrome or Bugarra syndrome. Associated with the cardiomyopathy, structural heart diseases like the ventricular dysfunction. That even causes the sudden cardiac death. That's why the ventricular, that's why we have to manage rapidly with the ventricular fibrillation. That can be the treatment with the immediate DC defibrillation or CPR. If the ineffective, or give the IV amiodarone. If ineffective, we can give the IV amiodarone or lidocaine, or and repeat the defibrillation again. Then treat the cause if the sinus rhythm is established. The premature ventricular contraction, where the here the this wave suggests the premature ventricular contraction, where here the ventricular tachycardia, there is a P wave followed by the white QRS complex, and the ventricular fibrillation, there is no P or QRS complex in fibrillation. This is a basic image of the defibrillator. You can use the metal pedals are there. You can use in the right upper hospital area, right infraclavicular area. Another is the right precordial area. We can give the shock according to the, that can be shock can be the two types. That is the defibrillation can be the two types. That is the synchronized defibrillation or DC cardioversion. Synchronized means we have to give the shock at the time of the peak of the R wave. And in the emergency condition, we can give the shock irrespective of the any ECG component.